that really talked about some of the progress and opportunities. Is that the next slide? There we go. That talked about some of the progress and opportunities, and really what we could do to strengthen the systems that we have in place in order to help them deliver on eliminating all three diseases. It was a very robust and rich discussion with a lot of great participation from the audience. In today's session, which is called Addressing the Social and Structural Barriers that Hinder Access to Vertical Transmission, we're going to take a slightly different perspective and hear really from individuals on a panel that will discuss some of these structural barriers that limit access, and try to unpack a little bit how we can improve access for young people, talk a little bit about men as partners and sometimes as gatekeepers that can be both an asset but also a hindrance to women accessing care. And we'll also talk a little bit about underserved populations and how we could modify our services to make them more patient responsive, women responsive, to be able to reach those communities. For those of you who are online, a little bit of housekeeping. You are muted so that there isn't inadvertent interference during the conversations that we're having here. But please feel free to use the Q&A chat that will allow you to put in questions, and we will be able to get to answering those questions later on during the course of the session. So we're very grateful to our sponsor Vive, who made this session possible, and their help and support in both this session as well as yesterday's sessions is very much appreciated. And so let's get started with our first speaker. Let me welcome to the stage Cecilia Senu, who is Executive Director for Hope for Future Generations, Ghana. And Cecilia will deliver our first presentation on addressing the social and structural barriers that hinder access. Give her a warm welcome, please.
Thank you very much. So, we are all aware of what is happening and the way we are all making sure that the triple elimination is achieved. WHO is actually leading this, and all of us are implementing it in our countries. It has become very necessary and very important. And so I'm talking about the structural barriers. Those of us who work in communities, those of us who are on the ground know what is happening. And we can only achieve this with the partner and all of us, because the woman is always at the center carrying 24/7 the baby, and we cannot do that without working together as father, mother, baby, family, with all of us as stakeholders supporting. So my outline is just to look at the HIV situation in Ghana and also the vertical transmission, key social and structural barriers, and addressing those barriers and recommendation. And so a lot of services are going on. We cannot assess this if there are barriers. And we all know the systemic barriers that we have in our various countries in Africa. And this is the time we need to push our advocacy. Please, next slide. And so the HIV situation in Ghana, we are actually having a low prevalence. HIV in Ghana is actually on the low, and we know the population that carry, although they transmit the virus most. And so if you look at all age groups, 334,721 in general, and looking at adults, we have 316 over that, and children, 18,229, and the child cannot actually have access if the mother hasn't got time or caregiver. And adolescents, 10 to 19 years, also have, the population is quite high, 18,850, And so if you look at the data, it's telling us the situation that we are in Ghana. This is where we have the issue, and I'll just talk briefly about that. And among females, the prevention of mother to child in females is 99.3. And also if you look at PMTCT as week, the coverage. And then progress that yesterday it was presented, the 95, UNA's 95-95. This is where Ghana also stands when it comes to that. And virally suppressed, the third 95, we are 90%, which is a good thing. So we still need to put in a lot of resources, a lot of support to achieve this. I mean, the next slide. So vertical transmission of HIV, I don't know if I need to get down there. Can I go down? Yeah. So vertical transmission of HIV is also something that we are looking at, and we are doing a lot with the support of all stakeholders and our government. And so vertical transmission, I think it's not something I need to explain. But in Ghana, Ministry of Health has implemented various strategies. It's not just Ministry of Health, but all stakeholders, civil society, communities, women, all of us are part of it. And we ensure that the strategies we use more at community level that is acceptable and accessible to the women and the girls, but we try as much as possible also to promote male involvement to ensure that we implement safe delivery practices as a country. And I know it's not different from other African countries. But we still have a lot of barriers. I think in most of the sessions that we realize that stigma and discrimination is preventing people from accessing services. And so in Ghana, many people, the moment we're still behind when it comes to stigma. When we talk about HIV, people still continue pointing fingers. And we think that we have a lot to do, even though CSOs are doing, government and everybody. And so fear of being shunned by society, knowing your HIV status, we still have it in Ghana. Some pregnant women from accessing HIV services, especially within their communities. There are still families that are sacking and throwing pregnant women away. Well, the moment they know, so people decide not to even disclose. 3 days today, I had a call from a young woman that I have worked with, disclosed her status to the partner. The following day, the family took her luggage and everything and threw her out of the house. And so we had to look for a place. We brought her home and settled her. So this still continues. Religious beliefs, we still believe because we still have this, when the things, you go to churches for prayers to ensure that you are healed from HIV, we still have that traditional leaders, everybody is using it. And so it's always the woman that suffers. It's also preventing people, so they stay in prayer camps and different places to access, to get this. So lack of national health insurance, a number of organizations and donors are helping her, but some pregnant women are not registered on NHIS, so they don't have access. But there are the Global Fund, PEPFAR, all of them, working through the principal recipients like WAPCAS, Ghana Health Service, all of them provide those services. But we still have that. And based on that, a lot of people don't have access to this. And so they tend to traditional leaders or traditional birth attendants for services. So they end up having those antenatal services at community level. Has to reach communities disproportionately suffer lack of access to healthcare services due to mostly poor access to their communities. We still have communities outside, you have to cross, you have to stay on rivers, hard to reach communities. So those pregnant women who are there end up giving birth at home, and so they don't really get the services they need to ensure that we achieve the triple elimination, the goal and other things. So these are key barriers. key barriers that we can talk about within this. Now we have some recommendation. You know, community sensitization, you can't do without communities. You can't do without the women. You can't do without the men who are the people, the families, and the communities. So we believe that community sensitization is very important. We have different models, different strategies to reduce stigma. It's important. Community sensitization via traditional opinion leaders. For us, we work a lot with queen mothers who are custodians of our custom, who are the custodians of women and young girls and everybody in the community. And so the moment these queen mothers take charge of the issue, they run. And queen mothers in Ghana are not people you just work with them and leave them. The queen mother in Ghana is there until her death. And so you use that strategy of queen mothers, we are sure that your intervention is sustainable. And so investing in the traditional leaders is very important. The religious belief, I talk about it, very important that we partner religious bodies because in Ghana, we are mostly Christians and some Muslims. And so when you work through them and bring them on board as partners, it also helps us. So we invest in community systems, which is very important. Healthcare infrastructure, you still think that differentiated care is very important. We have the policy, a lot of investment has gone into it, but there are certain services still that we thought that it's only healthcare providers who can provide it. But we believe that if we empower the communities, we empower the women, we empower the fathers, we will be able to implement the differentiated HIV services, TB services, malaria services, and it's very important. Next, if I still have. Wow. So we talk about few recommendations, improving HIV services uptake among pregnant women. We say poverty reduction, socioeconomic interventions for women, and we remove those barriers. NHIA registration, which I talk about, how to reach communities. We need to ensure that services get there. Community civil societies get to those hard places, so they need to be resourced. Integrated livelihood supports, LEAP, we have it in Ghana. We thought that providing those services will help people and empower them. They don't need to talk to the man, but if they have the services, they can access those. Provide transport vouchers for antenatal and ART services. Conduct NHIA registration. We are doing it, the PRs like WAPCAs, Ghana Health Service, who are PRs to Global Fund, are already providing those services. And so based on that, we are registering the key and vulnerable population. So I'm being informed that my time is up, and so I will just end up this and give the floor. But thank you very much for listening to me.
Let me look around the room. Anybody else interested in Queen Mothers or other things that Cecilia has discussed? Yes, sir. I'm not sure if that mic works, but this one.
All right, thank you very much. I think my first question was regarding the Queen Mothers, so well understood. My second question is, how are you working with other aligned ministries, for example, gender and other department associated with the issue of women in as far as HIV programming is concerned?
Sorry? How are you working with other departments?
Oh, yeah. There are gender ministry has Queen Mothers as part of the staffing, who oversees a whole region and the whole country. So our partnership with them, Ghana Health Service, the Ministry of Health, all of them are part of interventions. We try as much as possible.
It's just for the video because otherwise they can't see you speaking. Yeah.
We work with the Ministry of Gender has Queen Mothers as part of the staffing, and they work with us in the community, work with civil society. So we try as much as possible to integrate the Queen Mothers strategy into a number of government institutions. Ministry of Ghana, they all use Queen Mothers. And so you'll be seeing some of them. We are bringing some of them for some of the sessions. They are custodians of barriers on gender, women and girls. And when they are empowered, they have those services, they have those information. They are very knowledgeable when you invest in them. And they are there. They don't just go 1 day, 2 days. They are there until she dies or she's distilled. And it's not common that they are distilled. And so all the government institutions, civil society, all of us use them. Thank you.
Can I ask a question? Any other questions in the room? Please put your hands up. We have time for one more question. Yes.
Thank you so much. My name is Moffat from Malawi. Globally, we still hear some new HIV incidences among adolescent girls and young women. Even though that we appreciate that we have probably achieved the 95 targets. But these new HIV incidences which are happening among AGYW are also worrying. You have mentioned about queen mothers in our respective communities. To be very, very specific in Ghana, how are these queen mothers working closely with AGYW? At the same time, we also appreciate that ART coverage for the young ones, the infants, is also a challenge. For us to achieve the final 95, which is HIV suppression rate, we need also to look at the young ones, which are almost the toddlers. How are the queen mothers also facilitating such type of interventions at community level, just to make sure that AGYW's young mothers, they are also well taken care of? Thank you.
So we have Queen Mothers Association nationally. We have the Regional Association of Queen Mothers, and we have District Association of Queen Mothers. And so what they do is to partner the traditional leaders, other community traditional leaders. In our intervention as Hope for Future Generation, we implement AGYW, and Queen Mothers are one of the key groups of people that engage the young girls. And when they engage them, they talk more about the traditional ways of protecting yourself. They add condom, all right. They teach them on the ABC, which is completely missing. And they empower their mothers to support. So they transfer information and empowerment through their mothers to their girls. And they meet the girls separately. Some of the homes that the girls are, they find it difficult to break some of this conversation with their mothers. But the queen mothers are very open. We train them in communication and different things, so they engage the young girls. I think some of them are here, they'll be talking about it. The queen mothers are very powerful. I mean, all the things that they do in the communities, they own the communities in a way, so they engage. They might not reach different places because of resources, but those who are very close to the young ones continue engaging them. They don't only engage the girls, they engage the boys. Because transmission is not just one person, they make sure that they engage the boys. They also engage the fathers. You know, they listen to them. In Ghana, our mothers are very important to us. Most of our communities are paternal and maternal, and so respect to the mother. So you work through the mother, and the man listens to the mother. And so they take the queen mother like their mother. And so communication is all over, and they are very powerful. We just need to do more of it, but that is what they do. We have a group of them who engage and continue engaging, especially on weekends. They go to the communities and mobilize them, tell them stories, tell them songs. They are youthful. They teach them a lot of things that we have HIV among young adolescent girls, but it's spotted in certain areas, and those are areas that we are targeting with the queen mothers. Thank you.
Cecilia, thank you. We're running a little short of time. I know there's a few more questions, and maybe we'll be able to come back to them at the end. But let's move now to the panel discussion, which is, I think, the meat of this session. And I'm going to introduce Luann Hatan, who's Executive Director of Pediatric Adolescent Treatment for Africa. Lou, over to you.
Thanks, Shafiq, and lovely to be here with a wonderful panel. So what we're going to do for the rest of the session is really unpack some of the social and structural barriers to vertical transmission prevention. We know we have the drugs, we have the technology, and we have the tools to prevent transmission, but we also can't use them if women and young girls cannot access them. So addressing these barriers is a key step in building a bridge between availability, acceptability, having access, and the support, understanding, and confidence to use the prevention options available to us. So I have a wonderful panel which I'm going to introduce. We have two young people, young activists here from Ghana. So Winifred Opari and Tracybel Awusu, welcome. And also Deo Matambuka, who is the Executive Director from the Rwanda Network of People Living with HIV. And lastly, my colleague Agnes Ronan, who's the Head of Programs at PATA. So just as a place to begin our conversation and just try and center ourselves in terms of the experience of adolescents and young women, just in some of the barriers young people, Tracybel, face in trying to access HIV services, sexual reproductive health services. If you could just explain a little from your experience in working with young people what those barriers are. And then maybe just in the interest of time, I'm going to add a second question to that. If you could talk a little bit about the prevention services that are available here in Ghana. Thank you.
Thank you very much. Good morning to everyone. I'm Tracy Owusu from Ghana HFFG organization. And I'm in a project called HUYW project, which I'm a peer educator in it. We engage the youth to impact knowledge and to assess testing as well. Okay, to my question. The main barriers in Ghana here are stigma and discrimination and fear of being judged. Most our communities, their facilities are close to our relatives and other things, and even the health service workers, like the health workers, also intimidate some of us. Mostly when the youth comes to the service when the youth comes to the facility for a service, how some nurses and some health personnel the attitudes they portray to them is kind of way. So that pees them off. If you show me this attitude, I will definitely not come again. That's the main one. Some even go to an extent that I'll tell your mother that you are coming for a contraceptive or you are coming for a family planning services, which is kind of weird, you understand? And also, we have our legal barriers. They may say when you're not 18, you cannot access maybe a family planning services or other things. So they think, oh, I'm not 18, I'm 16. But I'm sexually active, so I have to protect myself. Since you are not 18, you cannot go to the facility for those services. Do you understand? And there are also limited privacy and confidentiality. Since our facilities are not, we don't have most facilities and have rooms for like sensitive conversations. Some consultations are being held under trees and other things. Relatives pass by, other things, other people pass by and may hear what you are talking about, may hear what your private conversations. And me looking at them, I have heard some people's own. I don't want some other ones to also hear my own. Definitely I will not go. That's our main problems here.
Discrimination, among others, which is something that is malpractice that is persist, especially to the context of our our culture. And we have seen this working as we piloted. Out of 120 families that we piloted in, at least 76% of them, now they are in peace and harmony, if I may say. Economically, they are supportive. They usually, men could go work for money. Instead of bringing to the plate on table, they could spend in the bars, taking beers and sharing with their men, but responsibility of home remains on the women, which was really by then so hard and conflict at home. But when we had this transition of engaging activities, of men engagement activities through the district level and the sector level, on the village level, we piloted among these families that had a high rate of conflict within. But now, 76, as I said, they are now in good terms and they are contributing equally and they are supportive. Then I think it would be food for thought for us men to keep supporting our women, our families. Because if we are the gatekeepers, we need to make sure that the gates are stronger. And inside, there is a mood of cohesiveness and sharing. That's what I would comment on related with these culture barriers, stigma and discriminations among communities with HIV positive, not only HIV, but health-wise. We need to go beyond HIV because there is economic issues that my sister mentioned. That is where even we need to focus on. When the mothers, they have worked, brought food on table, there is this opportunity that we share equally. But when the man makes money, instead of bringing to the food on table, they share with others outside the house, which is something that we need to change. Thank you.
Thanks, Dale. Just in the interest of time, we're going to move on, but we'll see. Yes, I'm watching. Thank you. Okay, just lastly, just to ask Agnes, just to talk a little bit around, you know, the people in our communities, the most marginalized, the most underserved, you know, just as health providers, you know, what is our perspective and our responsibility really in making sure that the most marginalized in our communities also access prevention services. So just in the perspective of health providers, if you could share something with us on that. Thanks.
Thank you. Thanks, Luan. So first of all, I really would like to acknowledge the IAS for giving us this platform to talk about these populations who are quite often forgotten, your marginalized populations, while we're dealing with mainstream health service delivery. And the challenges that we heard from Cecilia, Christabel, and Winnie in the marginalized populations, those challenges are even more magnified. And here we're talking about immigrants, illegal immigrants, and cross-border populations. We're talking about populations who are displaced due to flooding, all the climate change disasters that we're beginning to increasingly see. And so what I'm going to do, instead of translate and not speak with an authentic voice, we've asked some of our frontline health providers to speak to some of the challenges that they face. We will also hear about gender-based violence in the same conversations, because it's in those settings where GBV is rife and they're struggling to access the most basic services. And when you add GBV on top of that, it's all sort of magnified. And I think if we are going to close the last mile in vertical transmission, it's those pockets where HIV HIV is going to remain, and we will not close that last mile. So I'm going to ask Tech to play the video for us from health providers.
What we have noticed in the health system is the little information about what to do as a survivor of violence. Where does one go to receive care? And combined with this, there is a lack of clarity about the flow within the healthcare system. For GBV survivors, it's quite important that we train the healthcare providers and organize our flows within the the facilities for care and also disseminating in the community. How to report and receive care is also quite important.
We need awareness raising and community engagement for GBV combat and make the community aware of the existence of care facilities for gender-based violence survivors, promote community group talk, and make the community aware of the existence of care facilities for GBV survivors.
As well as small outbreaks of infectious diseases in places with crowded populations, we see many cases of sexual rape, sexual exploitation of minors, early marriages, polygamy, transactional sex, which for reasons related to lack of knowledge, taboos, and fear are not reported. Cases of sexual abuse of minors are often known to family members, and sometimes they make agreements with the abusers in exchange for their silence.
We see patients who come with suspected GBV assaults, but we refer them to special GBV clinics via police, and we don't manage them in clinics. Post-care is also done in the special GBV centers, as most cases lead to criminal cases. No one wants to manage them.
The challenge that we face from the immigrants or foreign nationals in terms of providing and maintaining a stable healthcare system is that most of them don't have identity documents or valid passports. So it makes it difficult to register them on systems like CCMDD, which stands for Centralized Chronic Medicines Dispensing and Distribution. And this is a model that we use as part of differentiated models of care. Them not being permanent residents in the country contributes a lot on losing retention, as they just choose to go to their country anytime they want, and they also go for a very long time without notifying the healthcare workers.
In my clinic, I have dealt with illegal immigrants. No passport, nothing. Since I have not seen a clear document saying I must deny them healthcare services, I attend to them, especially at ANC. The problem I have encountered is a language barrier where they do not know our local language or English. This has resulted to poor history taking because now I have to point or use sign language. Even with giving health education, it's very difficult because you now have to point a condom for them to understand that you are talking about safe sex.
It becomes much better when the partner is there and understands our local language. He will then translate. They honor their follow-up dates, take medication as prescribed, and are respectful to me. My only problem with them is language. Language is the only problem that I have.
It is difficult for us, as some they even have false identification, like a person can register with a different name today
In the next visit, they have another different name, making it very difficult to manage them because there won't be medical history to follow, even though they have. That person will be like a new person now. It is very difficult to help them.
There is a need to expand PMCT care in health centers located near resettlement camps and equip facilities with early infant diagnosis and viral load materials and equip units with trained providers. We need to improve the provision of these essential goods such as antiretroviral drugs, prophylaxis for exposed infants, and prevention of HIV. We have to expand the demand creation for preventive measures and universal provision of condoms and lubricants. Thank you.
So I would like to first start by acknowledging our health providers for sharing their experiences with us. But I think as we can see, the challenges are multi-layered. And I think we've only got 10 minutes in this session. We're not even going to start to touch the sides of the issues that we need to discuss. But I think it was really important to just highlight them and bring them to our attention. And I think what's most disturbing, what we're hearing is about, mothers trying to access services. And then if you think behind that mother is at least one child, if not more. So the impact of what's happening in the facility is far wider than what we're seeing in facilities. And I think in terms of, and very quickly, because I know I need to hand back over to Luan, but I think just very quickly thinking in terms of interventions, I know this is not the place or time to discuss it, but I think where we are in our different areas is to think about, we don't need to reinvent the wheel or think about new interventions. It's about the interventions that we already have, but adapting them to suit populations who are in cross-border populations. How do we support them? We've got peer support. We've heard about healthcare providers needing training around how to deal with migrant populations. And then supply chain, strengthening supply chain and making sure that those challenges are taken into consideration at higher level, not just at facility level. So we also have examples of best practices from a couple of countries. Mozambique has now got what they call camps which have at border posts which offer comprehensive service deliveries. So at country level, these are things that we need to be thinking about, especially as our borders are getting even more porous, climate change is even worsening, so this problem is only going to get worse. So, and then in South Africa, we hear about how the government has taken a multi-sectoral approach to try and address, because it's not just a health issue, it's a broader issue where in South Africa we've seen xenophobia with communities preventing migrants to enter facilities, but South Africa has taken a very strong stance in the fact that health is a human right. So where we need to, it's multi-layered in terms of where we need to even start thinking about addressing some of these challenges. So this was just a flavor. I'm hoping that IAS will give us more platforms to continue with conversations like this. Thank you.
Thanks for that, Agnes, and thanks to all the health providers as well. I know our session has come actually to an end, so I'm going to just try and draw a closing to the session, obviously thanking the IAS, also thanking Vive, and just really a reminder, I think everyone here on the panel really reminded us that we cannot treat structural and social barriers with medical solutions, yeah? And even though I think for many of us, we're part of all this excitement around, new, more convenient prevention options for women and adolescent girls and young women, and lots of excitement about lenacapavir and other prevention technologies. But again, these structural and social barriers are going to still remain a big challenge if we're going to be successful in being able to scale those prevention strategies. So just really in summary, I think just to focus on what was raised around stigma, and that it's still hard to understand and appreciate that in this day and age we're still facing stigma from health providers, and people who have such influence. We heard about the Queen Mothers, if I got that right. But just, how important that we need to unlock the doors, not keep the doors locked. So really trying to shift that gender inequality that continues persisting, and that still today we have so many women who do not have autonomy to make decisions around their own reproductive health and bodies, and are often exposed to high levels of violence, marginalization, and even in our region, high levels of xenophobia. The importance of male involvement. This is key, and yet we know that in so many of our prevention programs, we often still focus solely on women, and we don't really create the space, and often not an inviting space to engage and involve men. So how we really kind of shift those divides is really important. And of course, these structural, persistent barriers of poverty, transportation, service user fees. These are all things that we have to ensure that accessing prevention services is affordable. We need to make it convenient for young people in terms of distance, in terms of waiting times, and obviously in terms of friendliness. And then, of course, the legal and policy issues around age of consent or criminalization, and things that continue impeding our access. So on that, I just want to thank everyone for participating. I apologize that we didn't have time for any questions or answers, but I'm sure the panel is happy to hang around here if anyone wants to just come and have a conversation with us. It doesn't look like anyone's chasing us out of the room. So just welcome to come and have a discussion with anyone here on the panel, but I know that others may be wanting to join another session. So thank you very much.